welcome.
Thanks for having me.
For the audience, can you introduce yourself and give a brief overview of where you started your career and where you are now?
Sure. So as you said, I'm the CEO of Audere. We're a technology nonprofit, and we work with different AI capabilities that we either build, source, or test, and we integrate those into clinical workflows. My background is as an emergency medicine physician. I did that part-time and also went into healthcare management and have kind of straddled both during my career. And the last 4 years have been leading Audere as we kind of delve into this age of AI in healthcare.
Thank you. So we're both medical doctors by training, but I think you saw way more patients than I did. At what point in your career did you think, maybe I'm not going to be seeing patients my entire life, and maybe I like this other thing more, or I'm better at it? I'm not sure.
Yeah, so up until about 2021, like I was saying, I kind of did the two in parallel. So I worked part-time in an emergency medicine room practice. I always really enjoyed seeing patients. I probably did 4 to 5 shifts a month where I would see patients, but at the same time, my day job was more in the healthcare management space. So along the way, I'd done an MBA, and I both enjoyed the one-on-one interaction with patients and kind of that personal connection, but also the big picture, pleasure and thrill you get out of public health and leadership and management, and that desire to have impact on a broader scale in terms of number of people reached. I worked through 3 waves of COVID, and when I took the Audere job, there was both a little bit of burnout from the COVID period, but also I was straddling 2 time zones in the Audere job. So with a big part of our team based in Seattle in the US. Mm-hmm. So most of my shifts had been evening shifts or weekends. And I made a decision at the start of this journey to kind of dial back on seeing patients. I still help family and friends and would still like to get back into patient care at some point again. I do miss it. Yeah.
Okay, so it's not, you said goodbye to one thing and you started something else. You've been working in parallel. That's very impressive. Mm. What you said about your team, so you're the leader of a team, and the team is distributed across Africa and the US. So some of your colleagues are 9 hours behind?
9 hours and then 10 when kind of daylight savings changes.
Okay.
So it's a big time zone difference.
That means you have a very long day. You start your day when we start your day, but you end it when they end it, or?
Yeah, maybe I start a bit later. So I'll probably start my work day around 10 o'clock. I try and get some gym in the morning. I take my kids to school. But yes, I probably work until about 10 p.m. and that straddles the Seattle Pacific time zone until about midday, 1 p.m. their time. Okay. So at least we've got half the day that overlaps. Mm-hmm. And you're right, we have probably 30 to 40% of our team now in Africa, some in South Africa, Nigeria, Kenya, Ethiopia, and then a big portion of our team in North America, and the biggest portion of that in Seattle.
So what would you say is the advantage, if there is an advantage, to having this distributed team? And what is the biggest, so the challenge, I think, is obvious that you have these different time zones, but are there less obvious challenges?
I think one of the big advantages is we kind of get coverage around the clock. So there's a really nice handoff between the African-based team and the Seattle team on work, and whether it's dealing with customers or clients or different parts of our project, we've actually gotten into a really efficient flow of the handoff process and being able to kind of make progress across a very big time zone, and that's useful. Challenges are sometimes scheduling meetings. The kind of 3 p.m. to 8 p.m. time zone is very frantic because we're trying to schedule a lot of meetings fall in that compressed early morning in Seattle, but late afternoon in either Europe or South Africa or Africa. But we've made it work. I was skeptical at the start. There was a big push to have me based in Seattle when I initially applied for the role. Most of our business and customers, though, are in the African or European time zones. And we thought we'd give it a try with me based in South Africa. And it's worked really well to the point where my Seattle team are like, you can stay there. We don't need you in Seattle. So it also helps that we've got a very strong leadership team. And I have great colleagues that lead from that part of the world and make sure that our engineering is moving forward, our product. And on this side, we're engaging a lot with partners like yourselves, like others, as we build that kind of African infrastructure.
If we can talk a little bit more about the actual work that Audere does. So you said you develop, you source, and you integrate AI into clinical work streams. That sounds exactly what the world needs. Can you unpack that a little bit more? Like exactly what does that mean for a clinician or a nurse and a patient?
Yeah, sure. So maybe just backing up to the Audere story in a bit more detail to get to that point. The company was founded in 2018. The original founder was an ex-Facebook executive. He had done some work for the Gates Foundation, and there was a moment in time where the Gates Foundation said to him, we want you to assemble some of the best and brightest of engineers and product managers you've come across and put them into this elite unit that can focus on tech in the developing world and healthcare. Over time, we blended that with the best out of Africa as well. So we have this blended kind of global R&D and local expertise. About 4 or 5 years ago, we started transitioning more towards the AI space, and we started with computer vision capabilities, mainly around rapid testing. In the last 2.5, 3 years, we focused on language model services linked to computer vision and predictive analytics that can both help an individual with their self-care journey, can help a healthcare worker with decision support, and can help program leads with improved data. So at each level of the system, we have different AI offerings that either cover data analytics and predictive analytics, healthcare worker support, both in terms of supervision, advice, coaching, and decision support capabilities. And then importantly, our biggest portfolio is around self-care as a concept, and how you could potentially have an AI companion that you work with as a partner for your health information, your lifestyle information. Today I was meeting with folks around financial stress and how to put financial integrate financial aspects into that. Everything you need to be a healthy individual and to have peace of mind. Link that to diagnostic support through rapid testing and analytics that get to know you and both prompt you in terms of improved health behavior and take prompts from you. And then how does that link to services? So telehealth services, pharmacy services, e-commerce services, and the like. And it's been a really exciting journey just kind of learning about that, how people interface with AI, where the line is, what they're comfortable with versus when you kind of refer to a human. It's been a lot of fun, actually.
Cool. Thank you. A few follow-up questions. The one is, I think we all have this perception that the large language models are very powerful, but also that they've been mostly trained on data from the global north, primarily from the USA. So if we now use these large language models to help people in South Africa or Kenya or Nigeria, what does Audere and its partners do to prevent the chatbot giving information that's irrelevant or incorrect given the local context? And then a related question that I had was, if you have this chatbot, are there boundaries? Can you ask it to help you with your homework, or will it say, sorry, I haven't been trained, you can only ask me questions about these 7 things? So are there boundaries? Are there no boundaries?
Yeah, great questions. So earlier when I said we both build, test, and source AI capabilities, when it comes to language models, there's such an explosion of language models. They all have different characteristics, different features, different price points, different privacy and data policies. So a big part of our team's role is understanding what's out there. We then have what we call an omni-channel service model, where we can bring in not just one LLM or SLM, but multiple different ones based on their strengths and weaknesses, and funnel those through a service where you'll engage with an AI companion and you might be engaging with ChatGPT today or Claude tomorrow or DeepSeek another day, depending on how these features are changing. A big part of that is looking at privacy policies and understanding what happens to data, who sees data, and being very transparent and careful about that. There's a push in many countries now around data sovereignty. Just yesterday, I was meeting with a South African group who are looking at building a local model with a view to perhaps regulations in some countries around the world saying you have to use localized models because of data sovereignty concerns. So right now, that's not the case, but we're exploring local models too and how to partner. On the question of local context, local models help. But even if you're using ChatGPT or DeepSeek, the team does a lot of work around both the prompt engineering in terms of what it can discuss and what it can't, around the databases it draws from preferentially. So they call that a RAG, retrieval augmented generation, which is kind of pulling data sets specifically from one source before it goes to the wider internet. And then programming the tool with language support for South African languages, local slang dictionaries, local guidance in terms of healthcare, and most importantly, accurate local referral points. So does it refer to a localized group for mental health support, a local telehealth provider, local public facilities? We have Unjani clinics in there as a private option because they have such a big span. We have Discam and Clicks for e-commerce platforms in terms of pharmacy support. So a lot of the work goes into making it relevant and adding value to the user. And that's a big part of like how we think about the target product profile for these self-care tools.
Thank you. So what I'm hearing is it's not the off-the-shelf ChatGPT that anyone has access to. It's a customized, purposely developed and guided tool. And what I'm also hearing is that to do a good job, you really need to have local expertise and know-how of how the ecosystem works. Okay, that makes sense. Yeah, so that also means no one, like your purpose. I can imagine there aren't many other groups in the world that can do as good a job as you, because you need quite a bit of expertise in a lot of different areas to do a good job.
Yeah, we're set up for what we do. And like I said earlier, we're trying to take the best of global research and development and knowledge around AI tools and blend it with local partners, local engineering. Mm-hmm. Within our ecosystem, Vimy is our data science partner helping us with analytics. We have a predictive analytics partner that works on models for mental health screens, for HIV screens, called Phylaxis. We work with Delva, which is a research unit of Wits University that does a lot of the behavioral science testing for us with user groups, understanding how people are responding. We have a clinical partner called CHAPS who does a lot of the clinical labeling. So we have teams of humans that label de-identified conversations for accuracy. The accuracy could be clinical accuracy, it could be language accuracy, it could be empathy. We have a whole rubric of how we measure those. So it truly is a localized ecosystem of partners, and I've just mentioned a few. Mm-hmm. That we have an implementing partner, Shout It Now, who is a big kind of both liaison with government. They test the tool, marketing, support as one of our healthcare partners. So it really is, like you say, we've developed a specialized ecosystem to try and do this really well because we think it's so important. Yeah.
Can you share a little bit more about who has? If we continue on the topic of the AI chatbots and the self-care AI systems across all of your projects and clients, is it being used in government clinics? Is it in private? Is it non-profits? Is it all of the above? And has the experience? So there are. In terms of humans, it's the healthcare provider and it's the patient. Those are the two stakeholders who stand to benefit from using this tool. From your experience, what is the feedback that you get? I imagine it's mostly positive, otherwise we wouldn't be sitting here, but what, if you can maybe share a little bit more about that.
So I think it's still early days. We have a number of different streams that we've been looking at how to introduce the tool to. Because we're funded mainly by global philanthropy, it is very public sector focused for now. public sector and other non-profits using the tools. A big part of our funding came from HIV-related programming and work as our initial concept. So how to help people take their medication more consistently, how to help with risk awareness around sexual and reproductive health, and maybe getting on more prevention-focused tools. And in all the testing and the initial group, we've had great results. So 1 in 3 people, 30% of people who use the AI companion comes back to use it again multiple times. So it's like a 30% engagement, which is pretty high for consumer tech. The second key indicator is of that 30%, 1/4 we can track into a healthcare outcome. So they either had a telehealth consult, or they uploaded a self-test, or they accessed services at a public clinic and reported that, or perhaps accessed an e-commerce platform. So we can check and trace, and we've got mechanisms to look at linkages. So we're very encouraged. We would love to scale. The next stage is real scale. We've probably got 20 to 30,000 users right now frequently in South Africa on these products. We need hundreds of thousands or even millions. We're very excited about the data insights, the de-identified data insights from big user cohorts around what people are asking, what are their needs, where are their gaps in the system, because we think there's a massive quality improvement opportunity around that too.
Wow, okay. Let's see. So the group that is using it, is there an age restriction? Is there a minimum age to have access to the tool, or?
I'm trying to think now. I think there is a minimum age on the terms and conditions. I think it might be 15 or 12. I need to double check that for you. I should know that, but I need to double check that. You asked earlier just about parameters. We try and keep the conversations as broad as possible, because what we found from our research is people don't want narrow tools. They want tools that they can talk about their financial needs, their health needs, relationship advice. They use this massively. I'm having a hard time with my partner. I need to talk about this. Do you have any advice for me? Mental health support when people are feeling down. Those are some of the big areas. But right now, if you ask the tool about financial support and deep financial advice, it won't answer that. It's something that we need to add on. So there are limitations, and it's growing all the time. So we've started from this base. It's very health focused. But we're adding on other components on an ongoing basis. It's got basic mental health support, but we're really building that out over 2026 into a true kind of counseling tool. One of my colleagues was on 702 this week, and she got a tough question saying, isn't it a worry that humans aren't speaking to humans for support, and especially youth? And I think in a perfect world, we'd want people engaging other humans and trained counselors on their mental health needs. The problem is a shortage of counselors, a shortage of mental health services, and youth often not feeling comfortable opening up. We're seeing that with AI companions. They're a lot more open. They aren't judged. There isn't prejudice. They don't feel that a community member might, tell their secrets. So we think human interaction is critical, and you can't do without it in healthcare. But we think we're also filling a gap where people aren't having those conversations, or weren't, are now starting to have them.
Yeah. So when you were talking, so as you have said, WIMI has been part of the team that has analyzed some of the data. And so one of the things that you reminded me of is that the system is complementary to the brick and mortar and human healthcare force, and they refer to one another. So from the bot, you might be advised to go see a counselor or a nurse or a doctor. Is there also evidence that healthcare providers encourage AI bot usage? So is it referred to in both directions?
At the moment, it's more the direction of kind of the AI companion referring to a human. And specifically, we link it to like a telehealth platform. So we envisage this flow where you have an AI companion as your first point of triage and initial advice. When it comes to a healthcare decision, we prefer that to be via the human. So, if someone's talking about mental health and relationships and says they're feeling suicidal, at that point we want them talking to a human, and the AI is trained to push them towards a human. It doesn't leave them alone. It will continue to talk to them, but it won't tell them what to do. It will say, for this kind of decision support, you need a human. We need to link you to one of our partners. So there's the AI triage linked to the telehealth platform, and then linked to either e-commerce if they need to order and delivery, or into brick and mortar. And again, that could be government facilities or pharmacy facilities or private sector facilities.
Yeah.
In a perfect world, though, we are engaging various platforms. We're chatting to a mining group and saying, your miners have medical aid, but their families and kids often don't. How do you give them a product which both they can engage 24/7? And I think you brought this up on one of our calls, Vim, about one of the big data points we're seeing is like 40% of people engaging this tool after hours. Primary healthcare runs from 7 till 4 in South Africa, if you're lucky. But we see a lot of calls after hours, 1 a.m. in the morning when someone's worried and needs to talk. So coming back to the miner discussion, could mines, even though the miners have medical aid and the mines have health facilities, could you give them a round-the-clock tool? Could their families engage that? And could that drive traffic in both directions? The mine might provide the AI companion, but then it drives them more effectively at the right moment in time into a facility. Insurances, and you probably know more than me about this topic, but insurance products, you want the right person to access the correct and most affordable care at the moment in time. So could that be the AI companion, which is very cost effective? Could it be a telehealth consult, which costs less than seeing a doctor, then your doctor, and then your specialist care? If you can get more of that triage right, you save the system a lot of money. And I think that's, when you think about effective primary health care, it's a big part of the future.
One of the opportunities, and I think also challenges, that this new world opens us up to is, as you've said, it's not a tool with a very narrow scope. It's not, I can tell you whether you're sick or healthy. There's a whole universe of questions and concerns that can be addressed. That's definitely a beautiful opportunity. It's a game changer. I wonder, what's your experience with the funding world? Because traditionally funders say, we fund this thing. We are all about giving people access to HIV testing, or we are all about making antibiotics better or safer. Yeah. But now that doesn't make any sense anymore. If you have an AI tool that can guide populations across the whole health spectrum, and not even just health, but also education, also social dynamics, job opportunities, life support, more than just health support. How do funders respond to that? Are they getting it?
So there's two aspects to that. One is there's definitely a paradigm shift with what we're seeing with funders wanting to make broader tools that add value to the user. So when you make an HIV specific tool, it might be your objective to get an HIV outcome, but the user wants to talk about, we've seen like, my kids scream every morning when I put them in the car, it really causes me distress. Like, what could I do to help? That's their problem today. Eventually you build trust and you can weave in a question around, have you had a recent HIV test? Maybe you should think about one. But if you start with that, no one uses the tool. So this integrated approach and moving from verticals to horizontal is taking root because we see value, and funders are understanding that. The problem with the AI, or one of our challenges, is how to make it safe when you broaden the topic. So if you talk about a very narrow topic, you brought it up at the beginning, you can put guardrails, you can monitor that content specifically. At Audere, one of our biggest investments has been about how to monitor and evaluate the quality of the AI outcomes. And we've built two arms to that. One is human sampling of conversations and labeling to look for content and improve. The other is a software program and framework we've designed where we develop benchmark data sets of correct answers, so thousands of correct answers around sexual and reproductive health. And we use tech and a software approach to monitor the conversation. And if it hallucinates or makes a mistake, it's flagged by this framework we have in place. But you have to build those benchmark data sets for each topic area, which becomes more challenging. So we want to go broader, it adds more value. To keep it accurate and safe also takes more engineering and more effort. And we're trying to also kind of work with funders on understanding that. We talk about a consortium of donors funding our self-care work in South Africa, and we probably have 5 or 6 big international donors that are all funding components of it. It could be a disease area, or it could be the predictive analytics components. It might be the safety framework. So I think we're getting there in terms of kind of pooled resources.
Okay. So you've already spoken about monitoring and evaluation of the outcomes and the accuracy. So let's say that you put in all the work, you have the benchmark tests, you have the formal frameworks to confirm that the AI isn't hallucinating and it's actually giving correct answers. And it's doing that across a wide range of topics and diseases and human needs. Often after you've proven efficacy and effectiveness at scale, then the next step traditionally is proving that it's worth the investment. So it's some sort of cost effectiveness calculation. So this is where health economics comes in. When I was a student, I learned the different designs of health economics, and it was almost like an extension to a randomized controlled trial. So you have narrowly scoped alternatives that you compare head to head, and you ask, if this is the gold standard, is this other thing, maybe it's more expensive, but is it then also buying us more health for the extra dollars? Now that we have these systems that don't just offer one value or benefit, but countless numbers of benefits, what are your thoughts on this challenge of proving return on investment, given that the investment is fairly straightforward, but the return is so fuzzy?
Yeah, this is probably my weakest area, and maybe I'm curious your thoughts on the same topic. But you spoke about when we came up with the target product profile for a self-care companion. We've spoken about the value it has to add to the user, and we've gone through that today in quite a lot of detail. And the broader you make it, and the more, this is on WhatsApp. You don't have to download an app. You get it in a WhatsApp flow. You can talk about different topics: healthcare, lifestyle, finances, etc. The second was safety, which we covered. How do you make it safe that both governments and users trust it, both in terms of their data, privacy, accuracy, etc. And the third is this question of cost. We've done the least on the cost effectiveness side in terms of research. And it's difficult because, like you say, it's cross-cutting. So I think maybe you try and simplify it and you say, we know you get all this extra value, but why don't we start with some of the obvious questions? If you give someone a healthcare companion or a companion, and that companion could save 1 or 2 primary healthcare visits a year, where someone gets their questions answered or tests at home or can get meds delivered. What is the cost to the system in the most basic form of those saved visits versus the cost of the AI companion? So if you simplify it, you then start to say, okay, well, we know even in its most basic form, if it's helping prevent unnecessary visits to the ER or clinic, this is how much it would save. How does that compare to the affordability of the cost? From there, you can layer on a bunch else, and like the cost effectiveness argument only grows. But just at the beginning, to have people like using it and to see maybe we keep it simple. But to do it properly, to your point, would be more complex. And I'm not sure, like Vimy are more of the experts in the space. How would you guys think about it?
Yeah, I think your logic is workable. So if you say, let's make an exhaustive list of all the benefits, I don't think that's not a viable proposal, because that list would never end. And then to document to what extent and what is the probability that this conversation leads to this outcome or that outcome, where the number of outcomes is in the thousands, is hard. But if you say, well, we know it's doing way more than these 5 things, but these 5 things are the biggest sources of cost savings and benefit. So what's a really worthwhile outcome? Of course, it's going to be context specific. But in this part of the world, preventing HIV is a very worthwhile outcome. So if it helps you feel better, but it also helps you stay HIV negative, or it helps you to connect to HIV treatment or TB treatment, which we know is life-saving, then we don't really care about all the other smaller benefits. That's a bonus. Yeah. But it's point proven. by saving, as you say, saving human interactions in the sense that clinics and nurses are less overburdened, and we're spending less on the traditional healthcare, which is already overburdened, and then we get all these other benefits.
Yeah, and that's the last one. We often get the question, people say to us, could AI increase like inequality and equity gaps? So not everyone has a smartphone, although you only need a low-end smartphone for WhatsApp. Not everyone has internet coverage, like rural areas might suffer. But if you're able to lessen the burden on the system in urban or peri-urban areas, does that mean you can redistribute resourcing for improved clinics in rural areas? So even if the AI is working well in lightening the burden of care on urban or peri-urban settings, could that free up resourcing in the system to improve rural care, and that way kind of you have a little bit more equity and parity in terms of access, so it benefits everyone? Just you were talking about that now. The other thought is HIV is a great example. We have two very specific use cases around HIV. One is right now government is trying to do what they call decanting, and they take patients that have been good on with their ARVs and they say, we'll give you 6 months of medication. You only have to come back twice a year for your refill. But the patient has 6 months where he's not visiting a clinic. And the concern is, are they lost to follow-up? If they don't come back and you've done all that work to identify the patient and get them regular on ARVs and they go. So one of the partners we work with is Reproductive Health Institute in Gauteng province, where we're looking at how to test this as a companion to 6MMD. So you've got reminders built in, you've got information built in, you've got proactive outreach from the AI closer to appointment dates. And you want to keep contact with the person so that you know you have that connection. The other one is newly diagnosed patients, anyone starting chronic care, TB, HIV, NCDs like diabetes. It's hard when you start at the start of a journey. How do we turn these into like empathetic coaches that work with you for the first 6 months or year? That's the hardest part to get used to a chronic condition. The second one is prevention, and there's a new drug in South Africa that's been in the media called lenacapavir. So you can take an injection twice a year, and it's almost like a vaccine. It guarantees you won't become HIV positive even if exposed. But one, you have to understand you're at risk, so you need risk perception. Two, you need also to remember to go for your follow-up. And three, we want the right people using it, people that are at risk. And these AI companions can both help stimulate risk perception through conversations. Oh, I might be at risk. I've got 3 sexual partners concurrently. Len would be a good option. Or for people that are high risk, like sex workers, those types of folks you want on lenacapavir. The second one relates to the AI can understand your vulnerability score for HIV or for mental health and can flag you to the system as saying, okay, this person would be the ideal candidate. And then it can be a bit more pushy about trying to encourage you, or it can ask if you want to talk to a counselor and maybe link you to a human. So it's a little bit of that targeting and nudging that might be a little bit more once it's understood your risk profile for a certain condition. And that risk profile could be across many different areas.
As you were explaining it, I was thinking, so the focus so far, as I understand it, has been on optimizing the linkage to, well, not the only focus, but one of the focus areas is optimizing the linkage between the needs of a patient and the healthcare system and making sure that the care they need, whether that's preventative care or curative care, is provided. That's at the level of a single patient. I have a problem. The AI can help. Either AI can sort of address my concern and I don't need to see a nurse, or if the answer is actually you need to go see a counselor or a nurse or a doctor, then that is the advice that is being given. One of the other opportunities that I see, and it would only really come to fruition at scale, is to have a better understanding of the societal burden of disease and the societal needs. Because right now I think an entire country consumes healthcare, but exactly why they are there and what is being discussed during the consultation is not very visible to the world. It's kind of hidden in handwritten notes, or it's maybe in an electronic health record system. ICD-10 codes are absent or abused or incomplete. So if we want to know, for instance, what's the burden of burnout, or what's the approximate prevalence of people who have anxiety, a certain level or a certain type of anxiety, my sense is that if you have enough people using these systems, if you analyze the kind of conversations that they're having, you can actually get proxy indicators for those kind of things. And then you can say, well, actually, we are over-investing in this area of healthcare, and we are under-investing either geographically or disease-wise. So we can use it as a sentinel system, as a measurement of health and the lack of health.
Yeah, I mean, that's all very accurate. And even if you think about it from a pandemic preparedness or surveillance point of view, if you get decent coverage of people using these tools, and suddenly you get a lot of chatter around an outbreak of fevers in a specific area, you might understand that being a hotspot. And so it's both at a systems level in terms of what you were discussing as a surveillance level for disease outbreaks. There's so much that when you've got that broad data and you de-identify it so that you protect PII, but then you look at the trends, you can tell about the quality of services as a clinic, you can tell about disease outbreak patterns, you can tell about new drugs that are introduced in post-market surveillance. Think about pharma companies introducing a new product and how people are responding, what are side effect profiles, why did they miss their follow-up appointments. You really have a whole new pot of data that can improve a healthcare system tenfold, as long as you're responsible and ethical about how it's used. Yeah.
Okay, while I remember, so I want to invite our audience to type questions in the chat. We're going to continue our conversation, but if you start typing, then in about 10 minutes or so, we'll get to those questions. Can we switch topic for a moment and talk about what happened in January this year? I think the majority of our audience will know this, but the American system for health support, donor funding through USAID practically collapsed overnight. And I think there are signs that some of it is coming back on track, but at a reduced level compared to what it used to be. We know that a lot of patients and a lot of organizations who are looking after patients have suffered. There's an untold amount of suffering and health damage that has happened because of this dramatic change. My question is there anything positive that came out of this? Is there any shift, any efficiency gains, any innovation, any resilience that was born out of this crisis?
Yeah, I mean, this is definitely an interesting topic and one that's spurred a lot of debate. So I think starting off, I think every kind of sovereign country has the right and should be able to decide when and how they support others. So I think the US withdrawing funding is like within their rights. I think part of what is a bit unusual and disappointing about what happened was just the speed and kind of how it unfolded. And in an ideal scenario, you'd want someone who had been providing that level of support for so long to say, we are planning a staged withdrawal and we'll work with the government on doing that in a planned way. So I think that's part of what created the stress we were under. The stress did expose that a lot of countries, including South Africa, were reliant on donor funds, maybe over-reliant, and specifically the supplementary human resourcing that those funds provided. So when you think about PEPFAR and our HIV programming, we had a lot of supplementary staff and humans in the workforce based on the donor funding. What's had to happen is people have had to certainly be more innovative, figuring out how to do more with less. AI's had a role in that in terms of some of the functions we were talking about now, counseling, peer navigators, support. So I think there has been innovation. I think a crisis spurns innovation, spurns lateral thinking, and we've seen that in a lot of programming, but there's certainly been a human consequence to kind of the speed at which it happened that's been sad. it wasn't only like the US funding. I think it was the situation in Europe. I think global stresses generally mean less donor funds going into the development bucket, and it's heard from many kind of aspects.
Related question. So is there a world where the AI support systems that complement the traditional human healthcare provision is so efficient that it doesn't require external funding? It's either like it's completely self-sustained, maybe it even makes money, it's a commercially viable enterprise. You don't need to find a philanthropic organization. You can run a commercial company that makes money and helps people at the same time. Am I dreaming, or is that?
I mean, I think we believe so. I'm obviously biased in this sense, but we believe so. We think there's good business models around it where you can provide affordable, efficient healthcare at a reduced cost using a combination of AI, telehealth, and correct referral when you need to. I think the costing studies we mentioned earlier are needed and will prove some of that. We think a lot of healthcare companies are experimenting with AI tools for efficiencies like other sectors. So I certainly think and we see the amount of venture capital going into AI businesses is huge, with those businesses presenting interesting use cases, both in healthcare and other sectors, on how efficiencies can be achieved. We still believe there's always an important role for humans in a healthcare system, for AI to work and supplement human work, not be a replacement effort. I think it's part of our philosophy at Audere. And we spoke about the consumer-facing tool earlier. We also have products that are healthcare worker-facing, where clinical portals have AI flags. The healthcare worker can see only once the person agrees conversations and transcripts. They have a chat function. So a lot of the thinking is how to blend those different interfaces.
I think, if you don't mind, I would like to end with two questions. The one is, so much of the conversation today was about infectious diseases. As we know, in a big part of the world, there's this slow but really strong transition from infectious diseases to non-communicable diseases. So diabetes, cardiovascular disease, obesity, and mental health are growing in relative size, and the challenge that the economic and the social challenge that they bring. Is that an area that Audere is also venturing in? That's my first question. And the second question is back to the value for individual patients. So when you share information with a system, it's valuable in the moment to get an answer. What I also find valuable, just anecdotally from wearing a smartwatch, is to see how you as a person have evolved over time. It's nice to see that maybe your resting heart rate is coming down, or it's also valuable to see that it's not coming down, it's going up. Maybe you have been accumulating lack of sleep over a long time and you're actually less fit than you were 6 months ago. And to see that is a warning sign, maybe I should do something about it. So my two questions, one is, what are the opportunities, what are the activities in non-infectious diseases? And then second one, completely unrelated, is patient portals. Is there a world where AI systems can also help us accelerate to create more valuable information for patients to learn from their own data?
Yeah, so I think the two questions are also related. So we are looking at NCDs. The biggest one is mental health is a huge focus, because in the public sector, it's just there's a big gap in service delivery. And we see that from what I mentioned earlier about people not knowing where to go or how to have these important conversations. In terms of wearables, it would be incredible to have an affordable wearable linked to an AI system, because you just have so much more data. You have, some biometric data. Within our tools, we provide a patient, when you engage with the self-care tool, we have a light EMR on the back end, which collects your data over time and presents it back to you. So you can see the conversations, how your trends. So we'll provide you with your own mini dashboard within your tool and your own profile. But having wearables as part of a primary healthcare solution that people can access at an affordable price, that give you data on blood pressure, maybe sleep, heart rate, that type of thing, would be huge in terms of just how much better the AI could do in understanding you and your risk, and in terms of wellness as a concept and managing some NCDs. So in my perfect world, you'd have the AI triage combined with an affordable a 50 Rand wearable that every South African could access or swap out or get. You'd have affordable telehealth for the first line with all that data flowing into the telehealth platform with a human. You'd have easy access to drugs for chronic care through pickup points, delivery, and limit time wasted at clinics where you have to sit in queues. And then you'd have referral into brick and mortar or humans when you really need it, and specialists up the chain. And if you could do that, geez, how much could we save?
And for me, the take home is that technically it's possible. So the vision is there, the technology is there, so nothing is stopping us.
I don't think so. I think we can actually get it done. Yeah.
Great. Thank you for this conversation. Let's go to our listeners. I'm going to scroll quickly. I think we have a few questions. Okay. Daniel still is asking, have you experienced situations where a bot gave incorrect advice or correct advice, but the patient then went to a healthcare facility and had a bad or an unexpected experience based on what was suggested by a bot? And then the follow-on question is, and would there be a feedback loop to deal with this, either a healthcare worker giving feedback on available services or a patient providing feedback to tailor future advice given to others?
Yeah, so we definitely have experience with chatbots or AI companions giving incorrect advice, and that's what I was talking about earlier in terms of that M&E framework we've built. When I say that, you have to also put it in perspective. One of the things we talk about is what is the benchmark of accuracy? And these AI companions, even the off-the-shelf ones, get things right, in the high 90% of the time. I can tell you as an ER doctor, I wish my accuracy and my certainty was that high when I was working with patients. So, it's a bit like a self-driving car. The data shows that, accident rates are much lower, but if one does crash, it becomes a national story. And it's like that paradigm that we're also trying to balance. I love the idea of the feedback loops. I think it's something we have in a rough form, but could do better on in terms of bad experiences or good experience either direction. I think the telehealth part is important in that feedback loop, because if you're going to a facility, maybe you feedback either via the AI or to the human in the telehealth platform, and you kind of need a translator for feedback in both directions. We're looking at as much system integration as we can find. So the more data points we can integrate with back and forth, the better, right? So if you think about chronic dispensing of medication, National Department of Health has a program called Sync, especially for HIV programming, which gives you data on people in chronic care. How do you have data flowing from the self-care tools into Sync and vice versa? And with EMRs that exist, within other sectors, how do you have the self-care platform feeding into the doctor's EMR and maybe data from the EMR into informing the AI tool that the consumer is using? So I think the feedback loops are important for a number of reasons. And that's a great point.
Thank you. The other thought I had when you related to this question is, with these systems, we can actually investigate and quantify the percentage of time that the wrong answer is being given. But in the analog world, we don't. So every time a nurse or a counselor or a doctor says something that's not entirely correct, we will never know.
Yeah.
So it's hard to then say what is good enough, because the AI might be outperforming the humans by a lot, and we wouldn't not necessarily know. So I think the ultimate proof is, are the health outcomes moving in the right direction, and is that move faster than before? So if we accept that mistakes will be made, but let's say connection to pre-exposure prophylaxis for HIV prevention happens at a certain rate in the absence of AI, but with AI it happens at double the rate,
100%.
Then that's the answer.
Yeah.
More than, oh, there was 1 in 1,000 gets the wrong advice. Maybe that's not really the.
Yeah, I think the way you're suggesting it makes perfect sense. You could do a study where you record healthcare worker or counseling conversations and compare the recordings on accurate advice and accurate empathy. You know, the human touch is undeniable, and AI is never going to hug a patient. But at the same time, AI also never has a bad day. Like, it never has a fight with its wife before it goes to its partner before they go to work. It never is sleep deprived and from working last shifts. So you kind of got, again, I think the blend is the two working together, where AI becomes that important backup for human empathy and human touch and human. But error rates with AI are very low, and it doesn't have human fallibility either.
2 more questions. So the one question is, in your work on HIV, do you have data on the key outcomes like reducing treatment disruption or increasing PrEP use? Let's start there.
Yeah, so on PrEP use, we have a lot of data, because that was the original research study that was designed, that we were funded. We had an AI companion called Amy, and Amy was built for adolescent girls and young women. It's just had 8 months of data collection. And I mentioned earlier that 1/4 of that engaged group was having a care outcome. 10% of that was PrEP uptake on young women who probably wouldn't have thought about PrEP before. So some really interesting data of how it's driven PrEP uptake in that group that we'll be publishing on in the near future. On treatment disruption, we are in the process of just launched in KZN on a tool called Coach AI, and this is the aspect of our AI that's going to be focused on adherence and adherence support. So we'll probably be doing data collection over the next kind of 6 to 8 months on that tool, and we'll have comparable groups to look at adherence with the coach versus without, and watch the space. We think it will be positive, but we'll have to see. Yeah.
Thank you. And then another question, are there any specific laws that cover you as a healthcare provider as your patients use the AI companion? Who is ultimately responsible in case a patient misinterprets or uses information the wrong way?
Yeah, sorry.
We also skipped the question, but we can go back to, we can first do that and then go back.
So I think there's a lot of effort to work with regulators on that area, which is somewhat of a gray zone. I think we vie away from the AI being decision support, and I was mentioning this earlier. At the point where there's a key healthcare decision, like what medicine should I take, or when someone mentions suicide, at that point the AI is really programmed with the hard stop to refer to the telehealth consult or to the mental health provider. So the tool isn't meant for decision support necessarily. It's meant for triage, like I said, information. Will people take information interpreted the wrong way? What will happen in those cases? I think it's a new field. I think the risk of that happens when any time a doctor gives advice in a room, or a nurse. The good thing with AI is we have the transcripts. We can see what the AI said. We can see objectively what the outcome was. Again, you probably don't have that with 99% of health practice as it is. Handwritten records that are not legible. Who knows what actually happened? So I think the one thing it will give us is more transparency into the conversation, the outcome, and the regulators are definitely looking at all of that and trying to balance these different pros and cons.
Great. So we have a question. Despite these solutions offering cognitive offloading, more accurate and streamlined systems, there still seems to be reluctance from providers to adopt these strategies. What do you see as potential solutions to improve adoption in our diverse healthcare system?
I think we're seeing a mixed bag. I think in some of our work in East and West Africa, we're seeing providers welcome these tools and use them. But then in others, anything that adds workload or an extra burden to a provider, they don't want to adopt. One of our board members was interviewed, a guy called John Halamka. He heads up Mayo Clinic's platform. And he was talking about when presenting digital solutions, doctors want to know, will this help me go home half an hour earlier to my family? Like that's what mattered, So a lot of it is about time and workload, and less about other factors. So as we design these and as that we make them health worker facing, we need to understand what matters to the health worker, and it's not always the things that we think. So I think it's a mixed bag. We are seeing uptake in some areas, and others they push back, and often it's related to how difficult, how time consuming, or how much convenience does this type of tool bring.
And I think there's also the deeper challenge that if a healthcare worker was incentivized to create an outcome where they don't see the patient ever again because the patient stays healthy for life, then the whole dynamic would change. So now if you have a system where there are some perverse incentives where seeing the patient again and again is actually economically good, then maybe you are less excited about tools that help you not see the patient so often.
Yeah, I think how systems are incentivized is important. I think there is a fear about AI threatening jobs in the health space, which also sometimes leads to reluctance. So again, we position it as, the healthcare worker working with AI will be the preferred healthcare worker versus one who doesn't in terms of safety and efficiency. And so we're trying to encourage healthcare workers to see it as an ally. But for sure, there's a lot of concerns when something's new. Some people embrace the new, some people are concerned. You get kind of early adopters, middle, and we're seeing that whole spectrum.
Yeah. So maybe the strongest predictor of using it is having your colleague use it, and now it's at some point it's going to be silly not to use it.
Yeah.
Okay, a few more questions. How do you handle data security and ownership for patients, bearing in mind POPIA, HIPAA, and other regulations?
Yeah, so we have an entire legal team that looks at that. We build our products that are compliant with HIPAA, POPIA, and all the like. The custodian and owner of the data is the patients themselves. We are, we have access to the data, but we don't own the data. And we, again, in terms of the AI products that we might use in building, or tools that we might use in building our products, there's a very strict review on their privacy data policies to make sure that those align. So some LLMs we don't use because they might say, for instance, we'll use this for training data to train our LLMs, and we think you need consent for that. You can't just take it and use it for. So we've actually eliminated certain LLMs that don't fall within the data parameters that our legal team and framework have outlined, but certainly POPIA and HIPAA are top of mind and things we do our best to comply with.
And then the last question we have time for is, could you speak to the risk of AI failures and the dependencies created when implementing AI in healthcare, especially in resource-limited settings? How can we ensure these technologies do not deepen existing inequalities or create new vulnerabilities?
There's quite a lot there, so I'm trying to unpack it. So again, I think there's a few things. One is AI will have failures, and what's the benchmark and what are we comparing it against is important. I think we've built these safety nets, these M&E frameworks where we do our best, and that's actually, like, out of all the investment we've had, probably the biggest chunk of money goes into monitoring and evaluating the quality of the AI and what is its error rate and trying to improve that, and having transparency so we can show a government or a company, this is how the AI is performing, this is where it makes mistakes. Like, transparency has to be the number one value when using AI. In terms of the inequality gap, I touched on this before. Not everyone will be able to access AI tools right now. That's true. But if you're saving the system money at various points through people using AI, can those resources be redistributed to parts of the system that need it more, which might be rural areas? So maybe the AI doesn't arrive in a rural clinic up on the top of a mountain that doesn't have connectivity, but maybe you can place an extra healthcare worker there because in Durban you've been able to shift around resourcing because there's less people visiting that Durban clinic. or that Joburg clinic. So does AI help with better redistribution of resources that benefit rural populations? And that's something we hope will happen and we should look out for. You can also build AI tools at various levels that make access. Maybe you don't have it on WhatsApp on a smartphone, but maybe you're able to send AI generated messages to a feature phone. So there is still some AI service. Maybe you phone a line and you have an AI avatar that's able to engage on a voice call with information through through an older feature phone. So we're looking at different points. The AI might not look exactly the same in terms of a WhatsApp through a smartphone, but can you still access information generated by it?
So as humans, we have agency to steer how we use this AI and whether we proactively use it to help shrink the gap or grow the gap. Yeah. I think this is all we have time for, but I want to thank you again for your time. And I learned a lot, and I hope my audience did as well. We are going to take a break, but we are going to do more of this in the new year. Thanks so much.
Thanks.
Bye.